we have such a bizarre system relative to just about everywhere else in the world, it seems like. And you basically tell the history of how we got here, and it involves three major, I guess, forces that influenced the almost like the cart before the horse system that we have. It feels like in terms of providing healthcare service. Walk us through. First, tell us who those three major players were, and then walk us through this history.
Okay, sure. The three major players that I look at in my book are the American Medical Association, also known as Organized Physicians, the Health Insurance Association of America, which people probably know today as AHIP, America's Health Insurance Plans. That's a trade association that represents commercial or for-profit insurance companies. And also Blue Cross Blue Shield. They are also insurance companies. A lot of them today are for-profit. But at a lot of the history I look at, most of those plans were nonprofit until the 1980s and later. So
let me just ask you about the Blue Cross Blue Shield, and then we'll go into we'll start on sort of tracking this history. But so who started Blue Cross Blue Shield? I mean, it was a nonprofit. So was it mostly charities, or what? How did Blue Cross Blue Shield come about as a nonprofit?
It actually came about on two different tracks. It was hospital systems that launched Blue Cross, and the plans were actually separate from Blue Shield, which were launched out of AMA medical societies. So it was very interesting because the hospitals were very supportive of the nonprofit mission of Blue Cross for it to be an insurance, but not an insurance company, an insurance plan. They didn't like to call, for example, their customers subscribers. They were members. The organization very much had a culture of nonprofit outlook, trying to provide the most generous policies possible and sign as many people up as possible. Blue Shield was also a nonprofit launched out of AMA medical societies. Their character tended to be different because doctors were more hostile towards them. Plus, Blue Cross was coming out of hospitals which were much more accustomed to charity, getting funding from local governments, local charity campaigns. So it was just a different outlook. So the physicians launched Blue Shield. They also had nonprofit status. But as they developed, in areas across the country, Blue Cross and Blue Shield often merged to become,
When did those launch, like timing-wise?
So the first Blue Cross plan launched in 1929, and so Blue Cross really spread during the 1930s. The AMA was initially very hostile towards them, but once the AMA finally accepted and approved insurance, which wasn't until the end of the 1930s, they went ahead and approved Blue Cross. They also approved the ability for their own constituent societies to launch these plans. But within the AMA, it was always, some people were very much for them, some people opposed, didn't like the idea of the medical societies being involved in it. So the way those Blue Shield plans develop really depends on what state or what area you're talking about or looking at.
Okay, so you write, and this is this is a rather strange experience for me, but to find myself, sort of in somewhat of agreement with Sean Hannity. Sean Hannity has, for whatever reason, and occasionally I listen, been touting some guy in some doctor, I don't know where it was, maybe in Kansas or something, he's just found out about, that has a prepaid physician group. And apparently this model existed in the 1900s through the 1940s. Tell us what that was and how that got edged out and what the merits were of that system.
Yes, if you go back and look pre-1940s, pre-1950s, the surprising thing about the healthcare market, well, first of all, it didn't look anything like it does today. There were all these different models of financing and providing health care. Some were run by unions, some by farmers associations, some by African American fraternal orders. There was just a myriad of different ways that people were organizing health care. Now, one of the most popular models and certainly the most elegant when you're looking at provision of care, quality of care, and most important for today's discussion is keeping healthcare costs down, were these prepaid physician groups. Prepaid physician groups. So first of all, you have the physician group. A lot of people probably thinking, oh, well, we have physician groups today. But if you think about it, our physician groups today are single specialty. So you will only find an orthopedic group only has orthopedists or only general practitioners, the pediatricians, or whatever the specialty might be. But these early prepaid physician groups were multi-specialty. So you would have all the different specialties operating out of one plan. That way the consumer, the patient, is just going to one spot in order to get all the different healthcare services that they need.
So you go to one office building, and there's a general practitioner, and then there's an orthopedic, and there's a dermatologist, and whatnot, that type of thing.
Exactly. And what I found in my research, too, is that it was just a great model because they really, the different specialties learned from one another. At the end of the day, it was customary for the doctors to meet together and discuss the difficult cases, the routine cases they didn't need to talk about, but, maybe the elderly lady with a lot of different conditions or somebody who they can't figure out what's wrong with them, they would get physicians from across specialties meeting to discuss how to treat that patient, care for them, or figure out their diagnosis. So that was great even from the learning perspective of physicians and, of course, the quality of care that of patients received.
And so
I'm sorry,
it would work.
Follow up?
I mean, so the way it would work would be I would pay whatever it is, $10 a person in my family each month, whether I need health care or not, essentially.
Exactly. But the big difference being that you're paying it directly to a physician instead of an insurance company. So that made a huge difference as far as keeping costs down because, first of all, you're cutting out an entire layer of administrators, supervisors, and corporate, rules and procedures. But the most important point about that is you're incentivizing the physician exactly as you should. You've probably heard, in healthcare debates, some people criticizing some systems, like our system, the insurance company model we have. Because of the way physicians are paid, they're incentivized to provide too much care to people with insurance. It's just the way they're incentivized. They behave rationally. All of us would do it. But on the other hand, I'm sure you've heard people criticize other systems. For example, I'll use England as an example, where not enough services are provided. Care is rationed. It's long waits to get surgeries that don't take a lot of time to get here, or cancer treatments. The great thing about the prepaid physician group is the physician had no incentive to either oversupply or undersupply care. Because if they were stingy about providing services or procedures, then word gets around, they lose patients, they lose profit. But if they're just for no reason trying to run up a bill, that doesn't make any sense either because they're just taking money out of their own back pocket.
So let me ask you about both those ends of it, okay? Because my understanding in terms of providing too much care, one example of that was borne out in that sort of famous piece that Atul Gawande wrote maybe a decade ago about two different towns in Texas, which theoretically should have the same health outcome, or did have the same health outcomes, more or less, but had more or less the same inputs in terms of demographics and whatnot, except for Medicare costs were about 20 to 30% higher in one town versus the other. And according to his piece, it was because the doctors in that town tended to own their own medical equipment. So when they're over providing care, it's like, hop into the MRI, for whatever ails you, because I got one. And why not use it? And the only reason why not use it is that it's not necessarily called for, and it costs more money, and it's just as effective to do something else, or maybe more effective. I mean, is that how we can understand providing too much care in that instance? And B, how does the advent of these advanced medical devices implicate that program today? Because if that's what we talk about when we talk about providing too much care, it seems to me, in your group, everybody could have their medical device that, well, let's all just agree that we're going to use these.
That's a great question, and I really like that piece that you're referring to. Prepaid doctor groups actually completely mitigate this problem. In fact, a lot of states have state laws preventing physicians from owning their own equipment for this very reason, from owning their own labs, MRIs, all types of equipment. But if you look back to the history, you see a lot of these prepaid physician groups had their own equipment. They had their own ambulatory surgery facilities and labs and such. And again, this was absolutely fine because there was no concern about them trying to just run up a bill that they're then just shipping off to a third party. The problem with the system we have today, the insurance company model, what I call the insurance company model, is that physicians, they want to oversupply care because if they run up a bill, of course, telling themselves they're just providing gold standard care, but if they run off a bill, what do they care? They're not stocking the poor patient with it. That would also prevent them if it's a patient who, they have a relationship with. But instead, they're just sending it to a corporation, right? A cold, bureaucratic corporation somewhere far away. So you can see how that's incentivizing people differently. If physicians own their own groups, their own prepaid groups, they don't have incentive to use the MRI machine if there's no need to. In fact, it just makes good sense in a lot of cases that some of them would own some of their own equipment because it would be easier for the patient to get this stuff done in the same place instead of going all over town to get the labs and the different things, but they wouldn't have any incentive to do it unless it was necessary.
But is it the cost of operating an MRI that is what incentivizes you, or is it that I've outlaid whatever hundreds of thousands of dollars to pay for it and I got to meet my monthly, I don't know, how do you get mortgage or whatever it is on the MRI?
Right. So physicians would only be incentivized to even purchase that MRI machine if they had a practice where they knew they would use it enough for it to make sense. Otherwise, they might say, I'm in an area where we already have enough saturation of these machines. I wouldn't get enough use out of it. It makes no sense for my practice to invest in this. But perhaps you're a physician practice where, I don't know, maybe you're orthopedist or you do something neurologically or something where it makes sense, then you would. But you see a lot of these laws have kind of built up and a lot of these problems have built up around this really strange insurance company model we have that the AMA created back in the 1930s that puts the insurance companies kind of in this cat and mouse game with physicians. Physicians don't have the correct incentives. They're being increasingly supervised and regulated by insurance companies, which nobody wants. But the insurance companies are doing this, keep putting more rules, and states keep putting more regulations to try desperately, and they keep failing to contain costs.
Right. All right. Well, let's move to and I guess the other angle I wanted to touch on was in terms of rationing, and to the extent that we have that in this country, it is broadly speaking, these the notions of how insurance companies want to make sure that they still have a margin, and they don't want to pay for certain things, or they slow walk certain things, or they, at least prior to the ACA and maybe perhaps in the near future, would have things like rescission or lifetime caps or annual caps or jacked up premiums for people who are more likely to use health insurance, right? I mean, that's all a form of rationing. So let's take us back to how this developed. So we have these prepaid doctor groups, and I would also I think it's probably necessary to have the caveat that in certain geographic areas, it may not be as viable, right? Because you don't necessarily have the same, it may not be profitable enough for people to be able to do something like this. Is that the case or no?
I don't know. I mean, I guess you could say maybe in rural areas,
right,
the practices would be smaller and you wouldn't have as many specialists. Perhaps it would be a pediatrician, a general practitioner if you were really out somewhere. But I don't see why it wouldn't be viable, particularly because they would basically, what would end up happening is people would buy into their local plan, and then the local plans would set up some kind of credit system amongst themselves so that patients could access care wherever they were, because people travel, people move.
Right.
But I think it's viable, particularly if physicians want to kind of get back, if we want the patient and the physicians back in the driver's seat of medical care, because right now we're caught in a system where the insurance companies are actually shaping the way medicine is practiced, because the way physicians and hospitals are reimbursed is very much according to a standardized treatment blueprint. And so the insurance companies are very much straitjacketing physicians and what they can do. A lot of the creativity is gone. A lot of the, hey, I understand that this patient needs something differently than this patient because of age or gender. I just know their background. They don't have that creativity that they used to do, because if they don't follow the steps exactly as the insurance company says, they're not going to get their reimbursement.
All right, so let's go back. So we had in the 1900s, early 1900s through the 30s and in the 40s, these prepaid doctor groups as one sort of, I guess, primary mechanism in which people would be able to access health care. And the AMA was worried about these things. Why?
Yeah, it's kind of an anxiety that's very hard for us to understand today, and that's because turn of the 20th century, first few decades of the 20th century, people were very freaked out, I suppose I should say, about corporations and corporate power. Today we're kind of used to Walmarts and McDonald's and massive corporations.
I'm a little freaked out by it. I'm a little freaked out by it, but okay.
But I think we almost cannot understand the level of anxiety, because mankind, humankind having existed for so many thousands of years, and all of a sudden you have these massive bureaucratic hierarchies that were very powerful, and especially in the United States, more powerful than the government often, unlike Europe.
And I think too, we had a politics at that time that was pointedly antitrust, right? I mean, you had Teddy Roosevelt specifically, within decades of this era, specifically going after these large, trusts, essentially.
Right. You had a lot of people, one faction within the progressives saying, is this really how we should even allow the economy to be organized? Should we force everything to stay much smaller? So those were debates that were going on. Now, within professions, you're looking at lawyers, engineers, doctors. They're also worried about, what is their place going to be in this corporate society? How are they going to keep their professional position if you have these gigantic, powerful, massive, bureaucracy running things? So quite rationally, physicians were scared of the corporation. They didn't want to become like the engineers, sucked into it and have to become part of it. So, with imagine managers who were not even physicians managing them. So the reason they so fiercely oppose these prepaid doctor groups, and it's such a shame they did, is because they were afraid they were going to turn into medical corporations. Just that they were nascent medical corporations. You had capital pooling, you had multi-specialty that showed, the different departments, so to speak. So the AMA really did quite a great job of shutting them down, certainly preventing their growth. In some cases, they did get them shut down because the AMA members, by and large, controlled state licensing boards. So physicians who crossed their will on any piece of policy stood to have their license pulled. And the AMA was very open about this. They talked about it in the Journal of the American Medical Association. They released warnings saying, we will come after you and have your license pulled. Also, the other thing they would do, because they had so much influence over hospitals, is have their hospital admitting privileges revoked as well.
So how much involvement at this point? So the AMA was big enough to be able to sort of control a lot of these state regulatory bodies. How much involvement did the feds have at that time?
Are you talking 1930s, for example? Well, I would say 1930s is when you're starting to have starting to have healthcare reformers who had previously looked at having some kind of government provision of healthcare pass through the states at the state level. And in the 1930s, it's the first time they're actually starting to look at the federal government to provide health care. And that's, of course, because we're in the Great Depression. The crisis, the economic crisis, is seen as an opportunity for a lot of reformers. And, of course, the healthcare sector looks like it's prime for reform, especially since the AMA has gone through the sector, shutting down a lot of the great financing and delivery experiments that were going on. It made sense that the government officials would look at this sector as a place to intervene. The 1935 Social Security Bill, which provides really the foundation of the modern welfare state, it looked like for a time there was going to be a health care provision in it, but in the end, President Roosevelt asked the Social Security Committee to strip it out because he did not want to have to go up against the AMA. The AMA is organized as a national body. It also has all its state constituent bodies and then county or city medical society. So you see it has a lot of political power to lobby, congressmen and senators and governors and state houses and the federal government as well. So that's when really the 1930s is when the push begins, though. Roosevelt does create a working group to look at this. There's a national health care conference. For the first time at the end of the 1930s, you have Senator Wagner offering legislation for federal funding of health care. So that's really where you see the push beginning to reform health care. And, of course, most famously, the following decade with Harry Truman, in the latter half of the 1940s, proposing national health care, health insurance, which then is defeated by organized physicians and insurance companies and business groups.
Now, so was this push was it for health insurance, or wasn't there at one point also a push to federally fund these doctors groups, or did that come later?
So that's the great thing that, would have been the great thing if the Truman Plan had passed, is the people in the Truman administration who were specialists in healthcare and looking at putting this bill together. I found in my research it was quite clear that they were hoping with the bill not just to create universal health care, but to kind of destroy the insurance company model that the AMA had created, because everybody, even the insurance companies and Republicans, Democrats, everybody realized this insurance company model was kind of a disaster and was going to cause costs to rise very rapidly and make it difficult to cover people. So the Truman Bill was an attempt to provide insurance. A lot of times they would use the saying prepaid health care. That's the saying, it's a synonym for insurance. But they were hoping to do a lot of this funding through prepaid physician groups. But as I mentioned, that plan was defeated. But if they had passed it,
what were the forces? Was it the AMA that defeated it because they were afraid of the corporation? Was it the insurance industry that defeated it at that point? What was the incentive for the insurance company to get involved? How did people step up to because at that point, right, they were doing stuff like life insurance or property insurance. Mm-hmm. What made them step into that business?
Well, that's a really good question, because in the 1930s, it's around 1938 that AMA finally, because they're starting to come under so much federal pressure, they've been stamping out the prepaid physician groups. They've been stamping out, the union-run health care plans, the fraternal orders. They've been beating back the market in every way they can. And because of the federal pressure, they realized, look, we can't just keep beating down the market for health care, or we're never going to be able to fight the government reform. So they continue to oppose physician groups. They don't want any, multi-specialty groups, but they finally accept insurance. But it can't be just any kind of insurance. It has to be this very specific model, this insurance company model, where insurance would be run through insurance companies that were previously either property and casualty or life insurance companies. And they think that by doing this, they can stay in the driver's seat, that they will make the rule is that insurance companies aren't allowed to supervise them at all, and they have to pay them what is called fee-for-service payments, which means they're paid for each and every service or procedure they offer to a patient. Even in one office visit, they're trying to offer different services and procedures to run up the bill. And so the AMA leaders think this is the best way. They'll accept insurance, but it's going to be this very, very specific type of insurance. And, quite rationally, insurers look at this and think, no way. There's no way. Why would we want to get involved with basically you guys tell us how much we should pay? That's a suicide mission. How are we ever going to turn a profit on that? So the insurance companies do get dragged in during the 1930s, kind of kicking and screaming about it. But they have corporate clients who they're already providing pension products and life insurance to. The corporate clients keep asking for health care benefits because, they're trying to prevent union organizing. They also like these benefits to keep labor turnover rates down. So there's a lot of pressure on insurance companies to join with the AMA in this. It's an economic project, and that the AMA kind of whole cloth out of nowhere invents this healthcare model, but it's also very much, and they say this over and over again, it's explicitly a political project, and that they feel like they need something, and this is the model, the insurance company model, in order to keep back any kind of government reforms. Something they can hold up and say, we don't need government reform. We've got this great model here.
Every chapter of this story seems to be a political response to stem the tide of what would be effective, most cost-effective, like a policy implementation, right? I mean, it's whether to prevent, I guess, unions from empowering themselves, or to prevent just average citizens from empowering. I mean, it seems like at every stance, even the fear of corporations ends up driving the growth of other corporations and the power of other corporations to intervene in this dynamic.
Oh, absolutely. And it's such an ironic story, too, because here's the AMA doing everything they can to prevent corporate power, and of course, it would take many, many decades for this to develop. But now physicians are in a position where they're no longer calling the shots, and they've built this model that's empowered the insurance companies over time.